the pressures have been rising for the past 3 years particularly, but in Birmingham this past winter has been particularly bad because we saw significant pressures in social care and the closure of our community discharge beds. So there were about 300 beds in Birmingham, 100 were closed quite suddenly just before Christmas in the autumn, and that has been the single biggest impact on our ability to discharge patients and free up those beds.
And are those coming back at some point? Is there
On Friday, I had a discussion with NHS England who said they would try and recommission those beds, but that might take some time to get the staff back to do that.
Right. Do you ever get frustrated working in a kind of, I don't know, is it too monolithic? Is it too fragmented?
It's too fragmented.
It's
So first of all, in answer to your question, do I get frustrated every single day? It is way too fragmented. So this is not an A&E problem. This is a health system problem that shows itself in A&E, and the staff do a fantastic job. And often, you know, we've had a lot of bad press, but every single professional group, every occupational group in the hospital has risen to try and cope with the additional patients pouring through the doors. And I'm so proud of them for what they've done. But we're not responsible for social care. That's the local authority. I talked to a lady in A&E this morning who said, I rang my GP, I couldn't get an appointment for over 3 weeks. I've come in here. I know I shouldn't.
Right. So you're stuck really between inadequate GP service, inadequate social care, just to caricature it. You're the bit where people can turn up and you have to see them on demand with a wait, and thus you have people coming through the door.
We're the one part that never closes.
Right. There's a sort of simple question. Am I being stupid? Could you build a wing? Could you build your own care home that would be much cheaper than the acute beds in which you're keeping people, and you keep them there rather than having them using up acute beds?
I would love to do that. First of all, there is no capital to build anything just
Right.
at the moment. What we've done at the moment at the Queen Elizabeth Hospital is we've opened every possible bed. When we opened the hospital, it's got 200 beds in the new building, more than it should have. We've also opened up the older building that we were supposed to vacate and put more beds in. For a time, we did run several wards in there for people who really required the kind of rehab care
lower maintenance.
Yeah. The problem now is we can't get staff. There's not enough staff around to do it, and we don't get funded to provide that care. There was more money around in the past. There's far less money available now. We don't get funded to do it. We haven't got the capital to convert those. Now we are converting our remaining two wards.
But just to be clear, it is much more expensive to keep people in your hospital. So this is a kind of fragmentation problem. It's really expensive for you to keep people in acute beds. It would be cheaper if the people who are responsible for social care took the responsibility, but instead of giving them the money to do that, we're wasting money on acute beds for people who don't need or want an acute bed.
And actually, sometimes it's quite harmful to have them in acute beds. You know?
Doesn't that make you mad?
Yes, it's too fragmented. I would love to be able to take care of what we call the whole pathway. So from start to end. Those older people in there, it breaks my heart to see an elderly couple being separated because this society cannot provide a facility to allow a married couple to be together. That is just not correct. It's not right at all, and we shouldn't put up with it.
Could you do it if they gave you the money?
Yes.
That's interesting. Now, your budget this year, are you going to hit it? I think the answer is no, isn't it?
Well,
you don't want to tell the Department of Health now,
no,
but that is basically the truth, isn't it? You're not going to.
We have, because of the pressures we've seen coming through, when we admit more patients through the emergency department, if we hit them over and above a certain level, which is for us 12, 13 outturn, so more patients that we admit, we only get paid 70% of tariff. Okay, so we get 30%.
The government gets a discount on your work. Right.
But it also means we've cancelled elective activity, which we're not getting paid for anymore. And to hit those targets, we will have to find another way of doing that work. So that we haven't yet worked through the budgetary pressures that these current rise in demand has led to.
My understanding is that you have a, what is it called, a sustainability and transformation plan. This is the plan to improve everything by 2020. That plan is that Birmingham hospitals find another 300 million of cuts, basically over doing nothing for the next 3 years. So let us face it, demand carries on up. There's really not much reason to think stuff's going to change apart from these care beds that'll come back. Demand's going to carry on up. You're already basically busting the budget, and you have to find 300 million more between you and other Birmingham hospitals by 2020. It's ridiculous.
No, when you say it like that, it does. But actually, Since I've been in management, which is a very long time now because I'm really old, we've been saying we're going to provide more care outside hospital. We haven't. Now, either we need to get real and do that and really build the kind of facilities. Now, we talked on the film about patients coming. A lot of the patients could have had care in another facility, but it's just not available. None of those patients did not need care. They all need care. But there is no alternative available at the moment. We need to provide the alternatives. There are other organisations who are supposed to provide the alternatives. We need to make that real, and we need to make enough capacity so that patients haven't got A&E as a last resort.
Are patients dying for bad care in your hospital because you don't have beds, or you don't have enough doctors, or you don't have the
No, we monitor
requisite
that very
resources?
carefully, and one of the things that the staff have done very, very well is manage the quality of the care and the safety through that. Sometimes we've let waiting times go, so if they know a patient is safe to wait 6 hours, then that's fine. We would prioritise safety and quality every time over any target.
You meet Jeremy Hunt. You're a big trust, so you're an important part of the Midlands health system. What does he say? Did you meet him today? I think you saw.
He came to visit the trust today. He saw and spoke to A&E staff at one of the hospitals. I think he does appreciate the problems, and we were able to share some of our frustrations with the fact that we're waiting for other organisations. So the cuts in social work, we've got 30-odd patients, haven't even got a social worker assigned yet to do their assessments, never mind start the process of finding some care for the people. So I think we were able to explain to him a lot of the frustrations we were feeling in Birmingham. Sometimes it's often portrayed as the hospitals just need to, I'll use the phrase, get a grip. Throughout all this, with all the patients we have with the delayed transfers of care, and in December we lost across the whole system like 4,000 bed days for people who should. We've managed to reduce length of stay by making the rest of the hospital far more efficient in what we do, and that is a great testament to the staff in everything they do. So we're reducing length of stay, we're being very, very efficient in what we do. But we need to crack this problem, not because of the money in the beds as the main driver, but because it's not good care for patients.
Dame Julie Moore, thank you very much.